Hey, good morning, everybody, and welcome to Health Talk. Every Monday, we do this for the half hour to start the day. And joining us here in the studio is Dr. Ryan Marshall from Community Medical Center. Good to see you again, sir.
Thank you so much for having me.
This is your second visit.
This is my third visit.
Third visit.
Yeah.
Well, we've adjusted the microphone higher because you're a tall guy, so you're not the least bit intimidating to us short people. But anyway, John King is right over there. I'm Peter Christian, and so now, Dr. Marshall, for those who did not have a chance to hear you when you were on before, tell us about your specialty. What do you do at Community?
So I'm a plastic and reconstructive surgeon at Community Medical Center, located in Building 3, and I focus on all aspects of skin and reconstructive aspects, cosmetic and reconstructive, and we take care of skin cancers. We take care of women who have had mastectomies, who need breast reconstruction. That's a big part of my practice. So do a little bit of everything.
Well, I noticed on the list of things you wanted to talk about today, you're going where angels fear to tread and talking about legislation on Talkback here, or Health Talk today. The Cancer Rights Act of 1998.
Right.
Tell us a little bit about what happened there.
So no matter what side of the fence you lean on politically, I think the Women's Health and Cancer Rights Act of 1998 was a great piece of legislature that Bill Clinton signed into law in 98, and it basically covers all aspects of breast reconstruction for women who are undergoing mastectomy. So if a woman has her breast removed for breast cancer or for the BRCA gene mutation, then every insurance company under federal law has to cover all aspects of breast reconstruction, and that includes surgery on the opposite breast to match up the breast cancer that was afflicted with cancer.
So if you have insurance, you're covered with this.
That's
for
correct.
sure. They're going to be covering the reconstruction stages of
Correct. Medicaid, Medicare, and then all private insurers have to cover all aspects of the reconstructive process.
Now, what happens when someone intended to get insurance, but they missed the deadline, discover they have cancer, and they're caught in that no man's land, or in this case, no woman's land, where they just don't have insurance, and they have to get this whole thing started?
A lot of times what we can do is work with case managers and social workers, and they can apply for a retroactive Medicaid coverage in order to get that woman covered for surgery and for her breast cancer treatment.
You know, it's interesting how different things are. My grandmother had cancer before, and I remember she never got reconstructive surgery because it was expensive, and it was back in the day. I guess this is probably mid-90s, not even to 98, but not past 1992 or so. And she had to have these little gel packs that she wore to kind of give the appearance that she had breasts still, despite the fact that they were gone.
Right.
And since then, my sister-in-law and other members of my family, they've all had reconstructive surgery, and I didn't really realize why, the different choices there, but I bet that act played a big role in that.
I think it did. I think that a lot of women and men don't know about the act and don't know that if they want to have reconstruction and if they want to have their breast recreated, then that is something that's covered. It's not an out-of-pocket expense for them. I think educating men and women on these topics is a really big part, and it's a big part of Breast Cancer Awareness Month, which is what we're in right now in October. So.
One of the things that I wanted to ask you about, and I know that you're a surgeon, I want to talk about the psychological aspect of this, because any woman, that's a good part of her self-image.
Sure.
And what happens when cancer comes in and devastates that image, and there's huge changes going on here. And so, how, in addition to physically helping to reconstruct, how do you help them reconstruct their body image?
That's a great question. I think that the one thing that I always tell women when I first meet with them, when they come to talk to me about breast reconstruction, is that it's a choice, and a lot of times it's the only choice that they get in the whole process, which is empowering for women. And they can choose not to have it done, or they can choose to have it done. And not all women want to go through the reconstructive process, but a lot of women do find that it improves their sense of it restores their sense of femininity and their womanhood, and it gives them back the body image that they wanted and that they grew up with for 30, 40, 50, 60 years. And so that psychological part of the process is a huge part, and it's something that I take a lot of pride in working through the women with and helping them guide them through the process.
Now, obviously, you've never had the surgery yourself.
That's correct.
But what do people say that it feels like after surgery? Do they feel lighter or heavier? Do they feel like something foreign on you all the time? I don't wear a watch, but when I wear a watch, it just bugs me. I can't stop thinking that I have a watch on.
Yeah.
And if I were to have to wear glasses, I know I would suffer every moment.
Right.
So I guess I'm kind of curious, how do people feel with, like, I mean, obviously there's got to be some different stuff in there. I don't know what it is.
Yeah,
You say plastic surgery, I assume there's plastic involved.
Well, you're right. So breast reconstruction can be done in two different ways. One way is using a woman's own skin and tissue, and that's called autologous breast reconstruction, where you're taking skin and tissue from the abdomen or skin and tissue from the back or even the buttock area sometimes, and you're moving that skin and tissue into the breast or where the breast used to be. Then there's implant-based reconstruction, which is kind of what you're talking about, where you're placing basically a piece of plastic and silicone into the chest area where the breast used to be, and you're reconstructing the breast that way. And in today's day and age, I'd probably say that 70 to 80% of the time you're using the implant-based reconstruction because the surgery is a little bit more straightforward and the complications are lower than if you're using the patient's own tissue. Having said that, women typically don't complain or talk to me about the fact that they feel that there's something foreign in their body. You know, they had breast tissue there before, that breast tissue had weight, and they have weight there now, and it definitely feels different. And a lot of women who have large pendulous breasts, these implants are feeling higher, and they may even feel better because they may not have neck and back strain that the breasts were giving them before surgery. They may not have the same pain after surgery. So it definitely feels different. I haven't had a lot of women tell me that they don't like the sensation of the implants or the tissue expanders. Yeah.
What about comparing the two? I mean, obviously there's got to be a reason, if the risk factors are higher, to go with natural tissue over plastic.
And I think mostly the reasons for that is that some women don't want an implant in their body. They don't want anything foreign. They want, if at all possible, they want to use their own tissue. They don't want a foreign implant. They don't want anything silicone, and so they choose to have their own tissue used. And then there's other specialized cases. If the woman's had radiation before, or if she's going to get radiation, that radiation therapy can affect the way implants look and feel, so it sometimes is advantageous to use the woman's own tissue.
Okay, we're up against our first break. Dr. Ryan Marshall joining us this morning. He's a reconstructive surgeon, plastic surgeon with the Community Medical Center. As it's Breast Cancer Awareness Month, and so if you have a question or comment, I know it's a sensitive topic, but it's something we need to talk about. Our lines are open, 721-1290. Dr. Marshall here to answer your questions if you'd like to ask them, or if you would like to ask the questions offline, we can pass them along to Dr. Marshall, just trying to be sensitive in that respect. So our number is 721-1290. You can also ask questions on our Facebook page, and we'll be right back. And we are back on Talkback. 721-1290 is our number. Just had one call a second ago, John.
Yes, Mark called in, wanted me to ask you a question. It has to do with the information gathering phase before someone makes one of these decisions. And he was wondering whether or not you let your newer patients talk to your older patients.
Sure.
To kind of get a feel for what they might feel afterwards.
Yeah, so that can be a sensitive issue. There are laws now called the HIPAA laws, which is the Health Information
Patient Protection.
Patient Protection Act. Thank
Portability
you.
Act.
Yeah.
Is it portability?
Yeah.
Ah,
I'm glad you guys know it.
well, I don't.
Something like that, yeah.
I know what it entails.
Patient Portability Act. Yeah.
Correct. You're not allowed to divulge any patient information to other people. And so what we'll do is we'll get a consent form from the existing patients or the women that I've treated in the past so that the newer patients can contact them. And that's something that's I wouldn't say it's uncommon, but it certainly has happened in my 1.5 years. Yeah.
But I would think that there are probably, just here in Missoula, several breast cancer support groups where women get together and say, at someone who's had it done and someone who's considering having it done, and they talk together and they share feelings and thoughts and that sort of thing. And I imagine that would be one place where you could probably get that done.
Absolutely. So those women can go to those support groups. They can, there's, as you would expect, there's hundreds of websites that you can go to where you can read about and talk. But, sometimes it's nice to just talk one-on-one to somebody and to say, hey, Dr. Marshall has treated you. What was he like? And some people are more willing and able to divulge more information in a private setting than they are a group setting. So maybe that's helpful for patients. So that's a good question. It is something that we do, we have done, and I usually encourage it.
So when you're doing the natural flush process instead of the plastic reconstruction surgery, I mean, if you have a full mastectomy, that's a lot of tissue to replace.
Right.
And all that tissue is gathered from the person, the individual that's going to have the surgery. Even once you get it all, reallocated up onto the chest, how do you make that look like a breast again?
Well, that's a great question, and that whole process is individualized, and certain women with certain body habituses don't really qualify to have their own tissue used as their breast. And I usually look at the patient, look at their body habitus, look at how much tissue they have, and then I ask them, what size breast would you like? If a woman who's, let's just say, 5 foot tall and 120 pounds, relatively thin, wants to have a C or a D cup breast, she's probably not going to have enough abdominal skin or tissue on her back to use for a C or D cup breast. So it's a highly individualized, specific process, and some women are good candidates to having their own tissue used. Some women are poor candidates for various reasons.
It's interesting that you would bring that up, because I know that oftentimes a surgeon like yourself is called upon by a healthy woman to increase the size of her breast or to reduce the size of her breast.
Correct.
So how does that surgery, which is purely cosmetic, how does that relate to rebuilding breast tissue after breast cancer?
So the two things you talked about, one is the breast augmentation, or what breast implants, and that's purely cosmetic, and that is similar to what we do with breast reconstruction when we're using implants. In other words, you're taking a piece of silicone or a saline and you're inserting it underneath the chest muscle or the pectoralis muscle, and that's the same process as we do when we're doing breast reconstruction. The breast reductions, where the women want their breasts smaller, that's usually more of a reconstructive classification for surgery, and that insurance companies will often pay to have that done. And they're paying to have it done because the women have large pendulous breasts. They have a lot of neck pain, back pain, shoulder pain because of these breasts. And that surgery is very different from breast reconstruction or augmentation. You're not using an implant. You're rearranging the breast tissue. It's a lot more involved than the reconstruction or the augmentation. So a little bit different there.
We got a call from Mike, and it's about HIPAA. That I looked it up. We were all wrong, but just minor mistakes. Here it goes. So it's the Health Insurance Portability and Accountability Act.
Okay.
Gotcha.
Anyway, I thought there were two P's, but it's two A's. It's more like HIPAA than HIPAA. HIPAA. Anyway, so Mike wanted to know whether or not you felt that the HIPAA law constrained you, whether or not you thought it should be changed or repealed in your practice.
In general, I think it's a good idea. I certainly don't think that it constrains me. There are some times where we get into situations where I want patient records from another doctor's office because it might be skin cancer, it might be pathology report that I don't have that doctor's office has, and in order to get those records from the doctor's office, the patient has to, or actually I'll give you a better example. A woman comes to me for a breast reduction. Okay, so she's been seeing her physical therapist for the last year for neck and back pain. Okay, so I'm going to submit to our insurance company to have her breast reduction approved, and I need the physical therapy notes from her. So I can't just call up her physical therapist and say, hey, send me over Susie's notes that you've been treating her for the last year so that I can send these notes to her insurance company as proof that she's been treated for this neck and back pain. She has to go to the physical therapist. She has to sign a release of information from the physical therapist in order for that physical therapist to send me her information. So it just adds.
Is it cumbersome?
It can be. It can be for the patient, depending on where they live, their their access to fax machines and emails and things like that. It's just another step that sometimes doesn't need to be there.
Now, has EMR or electronic medical records, has that changed that made HIPAA more accessible or more easy to work around or with?
The problem with EMRs, in my opinion, is that while the government mandates or starting to mandate that you have, do we need to take a break?
No,
Okay.
Go ahead, please.
That we need to everybody needs to have EMRs. They haven't set any restrictions on how many EMRs they have. So there's hundreds, if not thousands, of different EMRs, and every office has a different EMR. Community Medical Center has a different EMR than St. Pat's. We have a different EMR than Marcus Daly. So everybody has their own little EMRs. Every office is used.
It's almost feudal.
Yeah, it's so it's.
I'm just going to call WikiLeaks.
It's the only real benefit of these EMRs is you don't have to read doctor's handwriting anymore.
Yeah,
so
right.
That's a huge benefit.
That's
though.
a huge benefit. My handwriting is not that good. So
I will tell you this. Several years ago, when I first ran into HIPAA, several years ago, there was a really bad bus accident out by Clinton.
Sure,
Okay,
sure.
And they were bringing like 30 people into various hospitals, and I made the mistake of asking a hospital official, "Can you just tell me how many people and how badly were they injured?" Or we can't tell you anything.
Oh, is that right?
Wow. Can you tell me how many are coming? No, we can't tell you anything. We're just telling you that people are coming into the hospital. Above and beyond that, because of HIPAA, we cannot and will not tell the media anything.
Oh, wow.
And it was like, whoa. And so you had to do a lot of digging and reporting and whatever. And unfortunately, many of the facts were wrong because the hospitals did not feel safe in sharing that information with the media.
Right,
so
right.
Anyway, with that, we need to take a break. 721-1290 is our number. You have a question for Dr. Marshall. He's going to be here with us for about another 6 minutes, and we will be right back with more of Health Talk in a moment. All right, we're back on Talkback. Health Talk, I'm sorry. Talkback, that's in about 10 minutes. Anyway, 721-1290 is our number. Dr. Ryan Marshall joining us from Community Medical Center.
So a question for you. So we've got a new breast in the process, right? We don't quite have, I guess, for better way to say it, the final step being the nipple. We don't really have that yet, right? We've only got skin, possibly skin from elsewhere on my body, possibly plastic. But how do you make that look like a breast?
Yeah, so the most commonly performed type of mastectomy now takes the nipple out, so the nipple's gone. There are some surgeons and there are some cases where you can keep the nipple on, but that's in the minority of cases. So if a woman has a mastectomy, she's typically going to lose her nipple in the areola. We'll use her own tissue or an implant to recreate the breast mound. But just like you said, at the end of that whole process, there's still no nipple there. So we can recreate the nipple in one or two different ways. One way is to perform a small surgery under a local anesthetic with a little bit of sedation where we recreate the nipple itself to give it some projection off of the mound. Okay, that's the nipple. Then we can tattoo that area to make the areola and darken up the nipple. That's nipple areolar tattooing after nipple reconstruction. The second way to do that, and this is becoming more popular, is 3D nipple tattooing. So there's a guy here at Altered Skin named Dave Anderson who will perform the 3D nipple and nipple areolar tattooing, and the results are actually pretty phenomenal. It looks like, when you're looking at it, it looks like a nipple and an areola on the breast.
So it's actually a 3D effect.
Correct.
It's actually less 3D than actually imprinting on a raised surface because it's still flat.
It's still flat.
Interesting.
And it's not.
It's like shadowing.
It's not
or something?
flat. It's a contour. So you have a breast mound. So it's kind of it's an oval or a sphere, if you will. It's not a flat surface. So it's a contoured surface. And he uses different inks and different tattoo techniques to recreate that 3D visual effect.
Fascinating.
It's pretty cool.
Fascinating, yeah. All right, so we have a minute left. So we need to get some contact information. Folks who are going through this process right now, maybe they're scared, maybe they're nervous, don't quite know what to do. How do we contact you to get this whole thing started?
I think the easiest way to contact us is just to call us at Community Medical Center. We're located in Building 3. We're above Big Sky Surgery Center. The office number is 327-3895. or our website is liftaestheticsurgery.com or drryanmarshall.com.
Good deal. Hey, thanks for being with us.
Thanks for having me.
Always
Appreciate
a
it.
Pleasure having you on Health Talk.
Thanks so much.
All right. We're going to take a break. Come right back. We've got the folks from the philosophy department at UM on scene here in just a few minutes after the top of the hour. We'll be right back.